our first speaker for the day. Dr. Alicia Tucker, she's a general pediatrician at George Washington University here nearby. She provides care for her children in her general pediatric practice and also in a specialty clinic at Children's Washington. She works also with the National Obesity Institute with research focused on childhood obesity and its impacts in particular on patients with congenital heart disease. So welcome, Dr. Tucker, and I want to know your favorite fruit and veg.
Good morning. Shorter. All right. Hi, everyone. It has been really nice to be here this weekend with everybody. Some old faces, a lot of new faces. I've been really fortunate to work with Dr. Harlan and the team at GW and the Culinary Medicine program, where I direct our medical student programming. But clinically, I work at Children's National in our tertiary care, weight management, and bariatric program. This is my 10-year anniversary of doing pediatric obesity medicine. I started there in 2014, and this has been a really interesting decade to be in this space. There has been a lot of changes. There are a lot of things I could talk to you about, but I'm going to try to focus in on the pharmacotherapy because that's what you guys are here to hear about, but I definitely want to do a little stage setting before we get there. And I'll say my favorite fruit is raspberries because no contest if you've eaten raspberries. And then vegetable, I don't know. I like a lot of vegetables. I'm going to go with cauliflower, but mostly just because that's one of the few my children will eat and I make it all the time and it's super versatile. So thank you, cauliflower. See, I'm ready. Oh my goodness. All right, I have sympathy for everyone that's been clicking through their slides. This is a sensitive clicker. Okay, so just to set the stage a little bit about where we are. When we're, and this can be, again, a topic that I think can have a million talks offshoot of it. And so I want to kind of get us to where we're going, but I do feel like I need to just set the stage with where we are in terms of the state of obesity as a diagnosis in this country. It is based on BMI. We can also have a very long debate over the utility of BMI. And I am happy to recognize a lot of its pitfalls, but when we're talking about what is going to be listed and your ICD-10 codes and what these statistics are coming from, it's coming from the BMI. So at this time, about 2 in 5 adults in the US have obesity defined as a BMI greater than 30, with about 1 in 11 having class 3 obesity greater than 40. In my population, in my pediatric population, we see about 20% of children and adolescents with obesity, which is defined as a BMI greater than the 95th percentile. And nowadays, about 6% have what we call class 2 to 3 obesity, which gets into the 120th to 140th percentile over the 95th. And there's a lot of math that goes into that. But really, at the end of the day, what we're seeing is kind of rising rates of this more severe category of obesity, even as sort of class 1 obesity is flatlining a little bit. Sorry, I thought I had another slide in there. But we also recognize there's disparities that exist within those numbers as well. And so this is not universal across the board. The 2018 NHANES data points out a lot of disparities in obesity prevalence across genders and across different racial communities. But why do we need to talk about, I feel like I'm missing a slide. That's okay. Why do we need to talk about this? Because obesity itself is often a risk factor for a lot of chronic diet-related health conditions. I think Dr. Lustig did a really good job of demonstrating that that also does not mean that everybody who has obesity has a diet-related health condition, is sick from excess adiposity, right? These are things that should really be discussed individually. And what I like to emphasize when I'm talking to students and residents is that BMI is a screening tool. And that's a jumping off point to have more conversations with our patients and families that we might want to screen for some of these really common weight and diet related comorbidities. It doesn't mean that everyone has them. It doesn't mean that everyone needs treatment. But for the purpose of this talk, we're gonna assume that we do have patients that need to have that discussion and that we wanna be able to have a sensitive discussion about weight. And we're also going to pause even before we do that. And I really encourage everybody to ask permission before discussing weight. We have to recognize that healthcare has been a really stigmatizing place for a lot of our patients. There's a whole wealth of research on this. Healthcare is often ranked as the second leading cause of stigmatization for patients with obesity. So I think it's always going to partner us better with our patients and families if we can pause, if we can ask permission, and they can say no, right? And if they do, there's still a lot of important things that we can talk about without discussing weight or weight loss, right? We can all in this room have a good conversation, hopefully, especially after this weekend, about nutrition and diet and how to meet people where they are in those stages of change. But on the flip side of that, a lot of patients do want to talk about weight. And I think sometimes for, honestly, a lot of good reasons, people get nervous and get uncomfortable discussing it in healthcare, and then it doesn't get discussed. And people are discussing it. People are talking to their friends, they're talking to their families, they're buying books, they're going on TikTok. I have adolescents, so a lot of them go on TikTok. They're watching influencers, and they're getting some really concerning advice sometimes. So it does really behoove us to ask people if this is something they're thinking about, if this is something they would like support with, because there is safe and evidence-based tools to help people on their weight loss journey. So, see, I apologize. I think some of these were out of order, but this I meant to discuss a little bit before. But in any case, so again, why are we having some of this discussion? Because we know that obesity itself is a risk factor for a lot of these chronic health conditions, and that there is, this high level of association. On the flip side of that, I think the numbers that we present initially when we talk about the rates of obesity in the US, the rates of cardiovascular disease, chronic diet-related disease, feel really daunting and feel like, well, what can I do about that? And then when we reverse it and we say, well, what can we actually do to help? How much weight loss is needed to make a meaningful impact in people's quality of life and the burden of some of these chronic diet-related diseases? It's not that much. It feels like a much more, attainable goal for a lot of our patients. So we know that about 5 to 7% of excess body weight loss can decrease the risk of diabetes. 5 to 10% of excess body weight loss has been shown to clinically reverse NAFL, non-alcoholic fatty liver disease. Our body wants to have some subcutaneous fat. It doesn't really want to have that visceral fat, that fat that's stored in the liver, that fat that's stored around our organs. And so that's often the first fat that the body is going to lose. So these small changes, these smaller degrees of weight loss can also be really impactful. And I don't think that's always out there in the public consciousness either. And so if people feel like, well, I'd have to lose X amount to be on this place and then, healthy weight of the BMI chart, that's not going to happen. So where do I even start? And we can say, you know what, you can make these small incremental changes. You can have 10 pounds of weight loss and you're probably going to have less knee pain. We might be able to go down on the doses of your medications. And those are, really stepwise attainable goals for a lot of patients. So again, I think knowing all of this can feel really empowering. At the same time, it's hard, and we want to recognize that it's hard, and this is where we're going to kind of get into some of the discussion around the physiology and what our pharmacotherapy can help with. Weight loss is hard. Weight maintenance is even harder. We know that even in clinical trials, right? And so this 5 to 7% of excess weight loss with diet and exercise, this is in clinical trial scenarios. Sometimes you'll read up to 10%, but that's really in usually a lot of studies where they've got really close touch points with the healthcare team and dietitians and a variety of diet programs. And in the real world, it's often less than that. On average, when you look at sort of population studies of people that lose weight through lifestyle alone, it's in the 3 to 5% range, which again, as we saw from the previous slide, can be really beneficial. And so it's not to say that people shouldn't do that, But I also really like to set expectations for patients, because again, if they go into something, watching Instagram reel and seeing somebody who went on X diet and lost 60 pounds, and then they don't do that, they're going to feel like they did something wrong, or maybe get into extreme or even disordered eating behaviors. We want to kind of head that off at the pass and explain what's going on with their body. What are those realistic expectations they can have for themselves? So this is, why I want to bring this together with culinary medicine. I think these are different slide decks. Okay, we're going to see where this goes. I just am realizing this is maybe a slightly different slide deck, but that's all right. We're all going to look at this together, and it's all the same topic. So this summarizes a little bit about what I was talking about before in terms of just in the clinical trial setting, what these intensive lifestyle behavior interventions can lead to in the clinical trial setting. But long-term maintenance of weight loss is really challenging. Our bodies have a lot of counter-regulatory mechanisms. Our bodies want to gain weight and they want to maintain that weight. And a lot of compensatory things happen when we lose weight. And so we want to take this really holistic clinical approach, and a lot of evidence-based practice guidelines support this in lifestyle modifications, as well as considering pharmacotherapy and bariatric surgery for a certain subset of patients. So this nice little brain photo was pulled from your Health Meets Food courseware for those of you that are doing it. So I wanted to kind of include that here. All of these factors and more are influencing each other. So this is, again, a really complex web of factors that are going on from sort of the second that we eat food, our bodies, within 15 minutes producing, insulin, and we've got ghrelin, we've got CCK, we've got GLP-1, which we'll definitely talk a little bit about. We've got all of these gut hormones working on this sort of gut neuronal axis, and these are really all being regulated within our hypothalamus. And so this is kind of that internal regulatory mechanism that's trying to keep us in a more steady state. And so it's not just being affected simply by those gut hormones, though. It's being affected by our environment. It's being affected by our sleep and our circadian rhythms, our pubertal growth and development, and a whole host of factors. Chronic stress, all of these things are going to be affecting the hormones themselves. Some are going to be sort of social and behavioral factors, but other things are really going to impact this hormonal regulation. And that's one of the other things that I always really like to highlight. Like, hunger is real. We've all felt hungry, and that is a real feeling. And a lot of these other things going on are telling the body that it's hungry, even if it's times where maybe we don't feel like we need food. And I think that's a really important thing when we're talking about this type of pharmacotherapy, that we have found good targets that can help control that hunger. Hunger is a real challenge for people, and it's often not just something that we can sort of willpower away. So again, this complex neuroendocrine system is kind of regulating those hunger signals, those satiety, those fullness signals, and a lot of these different areas and different signaling centers have really become targets for some of our medications. So to highlight, because we are at a culinary medicine conference, and I think this is really, really important to say, none of these medications are listed as monotherapy, right? They're all studied in clinical trials looking at patients that are also being supported with lifestyle therapies. The evidence supports having a multidisciplinary approach when we're treating patients with anti-obesity medications. The goal is to also provide intensive nutritional and behavioral support for patients that are on these medications. And so I think this is something that gets lost a lot of times in popular media and things where it feels like we're just out there kind of throwing pills and shots at people. But I think for people that are doing this the way that it's intended to be done, this should be done as a really holistic approach with each individual patient. We have nurse practitioners and amazing dietitians at my clinic. I could not do what I do without our dietitians. I love them so much. Thank you to the dietitians in the room. So this is a really important component of using these medications. And this really highlights this. And I will often explain to, to a lot of the trainees that work with me, because again, I think this stigma is really strong. Like, why can't we just sort of willpower this hunger away? Why can't we just overcome these feelings? Why can't they make these lifestyle changes? And we don't do this for a lot of other conditions, right? And I think something like mental health and depression and anxiety are really good correlates where we would say, yeah, the medications work, and you could probably just take the medication and go on your merry way, but they're probably not going to work so well. They're going to work if you do the behavior therapy, if you meet with your therapist and psychologist and psychiatrist, and that's how we're going to kind of get this condition into remission for you. And I would say it's the same thing with obesity. Are the medicines going to work by themselves? Yeah, certainly to some degree. Are they going to work as well as they could? No. And so we see this really being replicated across multiple different medications when we look at both the drug alone and the drug plus the lifestyle. So again, I want to really particularly highlight this for this audience, and that the lifestyle piece is still going to be critically important. So what do we have to bring us to our medications? This is the list of currently approved anti-obesity medications out there. It is not a huge list. There have been, well, I'm going to touch on that a little bit later, but in terms of what we have and what it's indicated for, this group that falls under this category of anti-obesity medications is indicated for patients with a BMI greater than 30 or patients with a BMI greater than 27 and a diet-related comorbidity. There are some conditions highlighted here, type 2 diabetes, cardiovascular disease, osteoarthritis, idiopathic intracranial hypertension, I would say, obstructive sleep apnea. There's some that are sort of, for those of us that might navigate insurance, there's some that I would say are sort of on the official list. I think there's other things out there that we could often argue are also a weight or diet related comorbidity, things like PCOS, prediabetes. These are a little more of a gray zone when we're talking about what they're kind of officially labeled for and what insurance will approve, which is, again, a whole separate talk, but in terms of the clinical indications. So let's see if this is where okay, so these are also, just want to peek, okay. Yeah, so I am missing a few things here, but that's okay, because I'm just going to talk about it. So the way that a lot of these work, we have really 3 buckets when we're talking about weight loss, right? We can increase energy expenditure, right? We can get rid of that excess energy. We can decrease energy absorption, right? We can just block things from being absorbed in our body. We can decrease energy intake. So when we're talking about an increase in energy expenditure, right? So in a kind of lifestyle medicine standpoint, we're going to be, doing all of these great things with exercise and sleep and things for our metabolic health. In a pharmacotherapy standpoint, there's really nothing we have that does that, or at least does that safely. In the earlier 20th century, they experimented with a lot of things that had really dangerous and concerning outcomes, right? Giving people excess thyroid hormone, giving people a drug called DNP, which causes mitochondrial decoupling, very dangerous things that just naturally increase your energy expenditure. None of these medications do that. I think a lot of people will ask for medications that do that, sort of well, I don't know if I need to change anything that I'm doing, I just need this weight to go away. And sometimes people don't necessarily feel like they are in a category where they need to change their diet. And I also say that to get back to some of our earlier slides around weight bias and stigma, that I think there are a lot of patients that have an elevated BMI that are not out there eating an extreme amount of calories or extreme amounts of energy-dense foods. They have a variety of, physiological reasons that predispose them to a higher BMI. There's a lot of genetic variability, epigenetic variability. Again, all these sort of behavioral and socioecological factors. Because again, I think there are some patients that do feel like they have gone in to get support for weight loss and they give their diet recall and have been told, that's not really what you're eating. Please don't ever say that to people. Why would they? They're coming to you for help and then you're telling them they're lying to you about what they're eating. Not that anyone in this room would do that, but I have heard it time and time again. So I put that out there as a plug. Believe our patients, because there are certainly some people that are eating what we would probably consider a relatively healthy diet, but for them, for their basal metabolic rate, that's not enough to achieve weight loss. Even those patients are going to need to go down to have weight loss. And then that's our job to make sure that they do that in a safe and healthy range, right? That we want to avoid, again, patients experiencing disordered eating behaviors, extreme calorie restrictions. I don't know if I made this plug earlier, but if I didn't, I will say, whenever we're talking about food, whenever we're talking about weight loss, we also want to make sure we're screening for any eating disorders prior to even having these conversations. Super, super important. So for the purposes of this discussion, we're going to assume that our patient does not have disordered eating, does not have a history of an eating disorder, is interested in weight loss and wants to partner with us, has been making some lifestyle changes, has not been successful, and is interested in talking about pharmacotherapy. So we're going to talk about what our pharmacotherapy options are. So the one medication that we do have that does decrease absorption is orlistat. Has anyone heard of orlistat? Okay, oh good, there's lots of hands. Sometimes I say this to residents and they look very confused. It came out in the 90s. It's a lipase inhibitor, so that's why I say this is our only medication on the market that actually does decrease energy absorption. If you look at the adverse effects, I don't use this very often. People don't love things like steatorrhea or fecal urgency. It is, essentially a fat blocker. You're inhibiting gastric and pancreatic lipase. Oh, and I didn't say, and as we go through these slides, these are actually in order of percentage weight loss achieved with medications in clinical trials. So as we go through and we look at the efficacy, this is at the lower end of the spectrum in terms of anticipated weight loss. I think it does have its place for some patients because it's very localized to the gut. You don't see as many systemic side effects for patients that are on, multiple medications or have other contraindications. Sometimes this can be a good option. Because of the lipase inhibiting effect, it does reduce the LDL kind of out of proportion to just the weight loss itself. So that's, one consideration. But again, I would say this is probably not my favorite medication, just for some of the side effects that people tend to experience. I do want to point out, though, this is available over the counter. This is the only weight loss medication that is available over the counter as Ally. It's kind of back where the cold medicine is with the pharmacist behind the counter. But it is available in a lower dose. The 60 milligram dose is available over the counter. The prescription dose orlistat is 120 milligrams, meant to be taken with meals. I do have pictures in this one. Okay, good. So I have some pictures too, if you guys have not seen or encountered these medications. But this is Xenical, generic orlistat, or Ally. So our next medicine down the line is naltrexone and bupropion, which is sold under the brand name Kysymia. A lot of our medications that we use, as we mentioned in our earlier physiology slides, are getting to that neural feedback mechanism, right? And what it's really doing is kind of counteracting that compensatory drive to eat more as you're calorie restricting for weight loss. Contrave itself, again, these medications were created for two different reasons. Bupropion is Wellbutrin, for those of you that are familiar prescribers. It's a neuroepinephrine dopamine reuptake inhibitor. It works on, in the brain, it works on something called the POMC neurons. For those of us in sort of the pediatric weight management, there's a very well-described monogenic obesity syndrome called POMC deficiency, and these are patients that present with a very specific phenotype and very extreme early onset obesity. These neurons tell us basically to decrease our food intake and increase our energy expenditure. So if they are not working right, those mechanisms get a little bit out of whack, but that is really where bupropion is working. And then naltrexone is an opioid antagonist and sort of blocks the feedback of beta endorphins. So both of these medications are used for other indications, right? Bupropion is used for depression, used for smoking cessation. Naltrexone helps people with opioid and alcohol cravings and addiction. And so both of these medications work independently to reduce cravings. And so we see this very similar effects with food. Again, when we're talking about weight loss itself, it's not the most robust effect. We see about 5% excess weight loss with Contrave, which is not that much different than what we see with patients that participate in the lifestyle program. But what I will say I find clinically, because of this mechanism of action, for patients that do have depression, really struggle with kind of that emotional eating, this can be really effective. And sometimes when we're in this management world, it's a little bit of two birds with one stone, right? What is getting in the way of you getting to your healthy lifestyle goals? And for a lot of people, what might be getting in their way is, mental health symptoms, depression symptoms. And so this can be a really good combination therapy, especially since we know that there are certainly a lot of antidepressants out there that can predispose to weight gain. So this is also something, even just looking for monotherapy with bupropion, that can be really helpful. And this is what Contrave looks like for the actual brand name of Contrave itself. It's sort of a layer of bupropion and naltrexone, and you're titrating up. With any of these medicines that have titrations, I tell all my patients the lowest dose that's working for you is the dose we want. There is no reason to just sort of go week to week to week to week because it's what's on the website. I try to really kind of carefully check in with people as they're titrating. The next is phentermine. And phentermine, I think because of the fen, still gets a lot of side eye from a lot of people. I just had a resident in clinic with me the other day who was like, oh, I thought that was not safe. I thought that wasn't on the market. And so many of us, I'm sure, remember fen-phen. And I think this has really been, a major impact on the public perception, and totally understandably, right? I never fault anyone for being, suspicious or concerned about anti-obesity medications. But for those that might be less familiar, fen-phen was phentermine combined with fenfluramine. It was really billed as sort of a miracle weight loss medication. Lots of people were taking it, sometimes in less medical settings than they should have been receiving this medication. Fenfluramine ended up being linked to cardiac valve disease and some really negative outcomes, including death for some patients. It was pulled from the market. Phentermine was approved in the 50s and has been, continuously available on the market since the 1950s. Because of that, it has never gone sort of through the reapproval process. It is still only labeled for short-term use for 12-week usage if you're sort of reading your FDA labeling and fact sheet. In clinical practice, I will say a lot of people use this for longer. We also have a medication that we're going to talk about just after this called Kysymia, which is phentermine and topiramate, right? And so this is utilizing phentermine. This has been studied for longer-term use in patients with good safety and efficacy data. So I think a lot of us that work in this space feel very reassured by a lot of those studies as well. But I say this because phentermine is been around a long time. It is available as a generic medication. It has been really effective for many, many patients for many, many years. But I think there's still some hesitancy when we bring up that name, because I think a lot of people's mind automatically sort of goes back to fen-phen. What is phentermine? It's a sympathomimetic, excuse me. So it increases neurepi, it increases dopamine. It really helps patients in terms of appetite suppression, especially. And it's also found to be working on sort of that reward, pleasure, motivation center in your striatum and part of your hypothalamus. And so one of the things that people have looked into in patients with obesity and insulin resistance is that they've actually found a lower dopamine receptor availability. We know that patients with insulin resistance often, have higher rates of depression, and I think there's still, to be determined the exact mechanism of that, but that's certainly one of the theories out there. And phentermine itself does also kind of work on a component of that dopamine pathway. And so patients report pretty universal appetite suppression with this medication, as well as really decreasing those overactive food-seeking behaviors. And so as we're thinking about selecting medications too, there's a lot of talk in this space, which maybe some of our speakers later this morning will be talking about in terms of just phenotyping different patients in terms of sort of their drive. And a lot of people talk about this hungry brain phenomenon, right? That there are patients that just feel really hungry all the time, versus some patients that experience what we call hungry gut, where sort of they eat and they don't feel satiated, they don't feel full. And thinking about really what's driving some of our patients' behaviors can also help you think about what medication might be the best fit. This is phentermine and its different available components. It's sold as Lomira, it's sold as Adipex. It comes in a variety of doses. Tablets can be broken in half for titration. So in terms of ease of use and availability, it's actually a pretty ubiquitous medication to access. And then I had alluded a bit to phentermine and topiramate. So this is sold under the brand Kysymia. This combination really ups our efficacy. And so now we're getting into sort of higher weight loss efficacy medications in clinical trials. This has about a 9% efficacy in terms of excess body weight, a 9% excess body weight loss in terms of efficacy, I should say. And clinically, I will say I find that this is pretty consistent as well, that a lot of patients do lose in the sort of 10% excess body weight range, or sometimes more with this medicine, sometimes less, right? All of these medicines are, I would say, very, very individual. Some things work great for some people, some things work not so great for other people. And so just like we went back to setting expectations, we want to set those expectations before we start anything to say, this is the average. You might have this effect, you might have these side effects, you might have more weight loss, you might have less weight loss. So we can kind of go into it with everyone on the same page and prepared. But I have found this to be honestly a pretty effective medication for a lot of my patients. It is approved down to 12, so that's also a reason that I tend to utilize this often with my adolescent patients that need support with pharmacotherapy. And just as sort of a, honestly, anecdotal finding, I think a lot, and certainly there are still risks for adverse effects, a lot of the side effects of phentermine and topiramate seem to balance each other out. And so I find people that experience sort of a phentermine side effect monotherapy don't experience that as much with the topiramate. And I think there's a little bit of canceling effect. This is the way that this is dosed. It is, oh, interesting. Someone scribbled on. I promise I had a cleaner slide deck. So, okay. All right. Oh, there we go. Hi, Karen. Welcome. So Kysymia is available as a prescription. You do need individual prescriptions for each dose escalation. These are capsules, right? So we can't divide the doses or do any different titration outside of these steps unless you're prescribing the individual components, which would be off-label, and I'm not advocating for, though some people might do that. So that brings us to our GLP-1s. Oh no, I was talking for way too long. Okay. Which I know is probably what everyone came here to talk about. So I will try to wrap this up in 5 minutes. Our GLP-1 agonists, right? These are the medications that have been so much in the media, right? GLP-1 is a natural incretin that's secreted from the gut after eating. One of its primary functions is to increase insulin secretion in response to food. There was, in the 90s and early 2000s, there was a big interest in this incretin in treating type 2 diabetes. And our first GLP-1 agonist came out in 2005 as Byetta, if any of you treat patients with type 2 diabetes. I really like to highlight that for people because I think it's something that has really made it into the public consciousness in the past couple years with semaglutide really targeted as a weight loss medication. But we have been using GLP-1 agonists for quite some time. We have a lot of information. Those of us in the community that treat patients with these medications, I think, feel very comfortable with utilizing these medications with their safety profile. And again, it's not to say no medicine does not have the risk of side effects or adverse effects, but that we really have a lot of data on GLP-1 agonists. A recent study also, we have more scribbles. A recent study also came out showing cardioprotective effects because of sort of the fen-phen debacle, honestly, in the 90s, that we really look closely at cardiac effects of any weight loss medications. And so we're seeing really good effects there. I really want to also highlight down here, liraglutide, Saxenda, semaglutide, Wegovy, and tirzepatide, Zepbound, are what is FDA approved as anti-obesity medications. Ozempic won the name, and I don't know how. I have not really figured it out other than it hit the market first, and Kim Kardashian used it, and a lot of people in Hollywood used it, and my patients see all these influencers that talk about Ozempic. Ozempic is actually labeled for diabetes. And for you as a prescriber, if you go to prescribe diabetes and your patient, if you go to prescribe Ozempic and your patient doesn't have diabetes, it will get rejected. Wegovy is the formulation. Now, are they both semaglutide? Are they both made by Novo Nordisk? Yes. Do they have different auto-injectors that have slightly different mechanisms and different patents? Yes. But they're essentially the same medication. So Saxenda, liraglutide was approved first. This is a once daily GLP-1 agonist. Also, effective, but honestly less efficacy. When we look at these medications, these are all GLP-1 agonists, but not universal in their effects on weight loss. I know I'm low on time, so I'm just going to flip through real quick. This is Saxenda. As you can see, it's got a lot more parts. You have to screw the little pen cap on with your needles. It's a once daily injection. And then we got semaglutide branded as Wegovy. This is a once a week injection. We see up to 14-15% excess body weight loss with this medication at a year. This has certainly been a game changer for patients with type 2 diabetes. If you have type 2 diabetes and obesity in conjunction, this has really kind of changed the management of your diabetes. But for our patients that have really struggled with weight loss and weight maintenance, this has been hugely effective. Most of the side effects are going to be GI related. Most, I will say, are mild as people get used to the medication and the dose titration phase, but there are certainly people that stop the medication because of intolerable GI side effects. We know there is an association with gallstones and pancreatitis, though these tend to be, rare side effects, something we want to let everybody know about. And then I'm going to go through real quick. This is Wegovy. If you have not seen Wegovy, they're individual single-use pens. It's a pretty easy-to-use auto-injector. And then I'm going to end with tirzepatide, which is Zepbound, which is now Also, kind of taking the media by storm a little bit, this is Mounjaro, which again, the name wars have been very interesting to me. Similar to what we just talked about with Ozempic and Wegovy, Mounjaro is approved for type 2 diabetes. Zepbound is approved for the weight loss indication, though I never hear anyone ask me for Zepbound. They only ask about Mounjaro. And this has a even higher percentage excess body weight loss, really close to what we see with sleeve gastrectomy. So for patients that are, in the range where they're considering bariatric surgery, this can really kind of change that treatment plan discussion. I'm going to end there because I want to be mindful of our next speaker. Sorry I ran over. I know we'll have a little more time to talk on the panel. Thank you, guys.